Hello.
Thank you so much for coming today. Welcome to Internal Injuries in Athletic Training. I'm Megan Hunt. I'm the Vice President of Precision Athletic Training. Precision has been providing quality contracting and consulting athletic training services since 2009, and we've been doing CEUs for ATs by ATs since 2013. If you like this lecture, we hope that you'll check out our ever-growing home study store. I know a lot of you guys have already bought home studies, so thank you for that. And let your friends know as well, because home studies are the next best way if you're not going to be having bacon and Bloody Marys for CEUs. In your folders, you'll see a course evaluation. You'll see assessment forms. We also threw some note pages in there for you to take notes. We're going to ask that you fill those out and hand those back to either me or Mara at the end of the lecture. And at that point, we'll give you your statements of credit. You also have a raffle ticket, and we'll be drawing a raffle for fun prizes at the end of the lecture as well. For those of you on the webinar, you'll see these evaluation and assessment forms in the handout sections on the sidebar. Please take a second and download these files now, as you will not be able to do so once the lecture is finished. If you're on the webinar and you have a question, you can ask those in the sidebar. You can just type in your question, and we'll have one of our employees raise their hands and read out the question and get those answered for you. Before we get started, I'd like to let you know that we'll be taking a brief break between lectures, and I'll ask that you please wait until this time to refill your plates or use the restrooms, which are out the back and around the corner. We'll also be getting the server in for more drink orders if you so desire. I'd love to thank Donnie Hughes for hosting us today and providing this amazing spread. Thank you to our presenters for all of your hard work. Thank you to the employees of Precision Athletic Training for helping make events like this possible and being awesome in general. You guys, I couldn't do anything I do without all of you guys, so thank you. Without further ado, let me introduce our first speaker. Larry Staley is a 2012 graduate of Northeastern University's athletic training program, Phil Huskies. During his time at NU, he performed clinical rotations at Harvard University, Northeastern, and Stoughton High School. He also completed co-op rotations at UMass Boston and Curry College. Larry attended UMass Boston for graduate school, completing his MS in Exercise and Health Sciences in 2015. While at UMass Boston, he assisted in multiple research studies focusing on public health issues like barriers to physical activity, adherence to physical activity guidelines, and use of active transport systems and their correlation to cardiovascular fitness and obesity. He completed his master's thesis on the awareness and use of the Hubway Bike Share program and its association with weight status and other health outcomes. Larry has worked for Precision Athletic Training since graduating from Northeastern in 2012. He is currently in his third year as the head athletic trainer at the River May School in Chestnut Hill. Without further ado, Larry.
All right, good morning, everybody. Thanks for coming today. I think Megan did a pretty good job of thanking everybody that I would have thanked, so I think we'll go right into the presentation today. So today we're going to talk about sports-related internal injuries, mostly through blunt trauma to the abdomen. There'll be a few other exceptions that I'll mention as we go. So as we begin, first things first, I don't have any financial or commercial conflicts or affiliations that I need to tell you about. These are my slides, my opinion. So as we go kind of to the outline of today, we're going to start with a brief anatomy overview, some of the important topics. We'll go into general overviews of types of abdominal injuries, as well as an initial evaluation, some tips and red flags, things to look for. And then towards the end, what we'll do is specific injuries like the spleen, liver, and kidneys. Go a little more detail into them, their anatomy and function, MOI, signs and symptoms, things like that. So, without further ado, let's get right into it. So, around 10% of abdominal injuries seen in ERs are going to be from sports. Far higher number you'll see are from auto accidents. So these aren't a particularly common injury that we see. However, they can be some of the most dangerous and potentially life-threatening due to their subtle symptoms and then the deterioration of conditions later on. As you can see, the most commonly injured organs are listed there. We got spleen, liver, intestines, kidneys. Spleen, liver, and kidneys are going to be the most commonly injured through blunt abdominal trauma. We go down to children, are going to be more at risk than adults. It's for a few anatomical reasons. One, they're going to have less fat and muscles around their abdomen area for protection. Their organs are actually a little bit larger compared to their body size than we see in adults, making them a little more vulnerable. And then their chest wall is not yet fully developed, so it's not able to dissipate forces quite as well. It actually makes them less likely to break ribs, but more likely to injure organs underneath. In a specific instance, the kidneys are going to sit a little more inferiorly in children than they do in adults, making them a little more vulnerable. Another major factor when you're working with kids is going to be their communication and developmental issues. So really young kids, they may not be able to describe how they got hurt, how much it hurts, their symptoms. So that becomes important with these injuries because that oftentimes will give away that something serious may be going on. Another issue with children, they may not have the motor control to prevent themselves from falling. Falling is one of the leading causes of injuries in children, so that can add to the problem as well. Men are slightly more at risk than women for these injuries, and I don't even know if I wanted to put risk as much as have more incidences of, anatomically speaking, there really shouldn't be any difference. If anything, men should have more fat around their abdomen region as body fat distribution goes. So this is probably more from the incidence of sports like football and ice hockey, lacrosse, things like that. On the next slide, maybe. So quadrants and regions. We've all seen these before in our travels. For the most part today, I'll be using the quadrant system, right and left upper, and then your right and left lower. It's good to know the regions as well. It helps to narrow down what organ may be involved. So you can see on the top row your right and left hypochondriac regions with your epigastric in the middle. In the middle row, you're looking at the right and left lumbar regions with the umbilical region in the middle. And then bottom is the right and left inguinal or iliac region, and your hypogastric in the middle. So, like I said, for the most part, the quadrant system is probably good enough for what we are doing in our evaluations, trying to narrow down what may be going on. But, as you can see on this next slide, there's a lot going on even when we break it down just into regions. So these regions could have 3, 4 organs in them. Some of the organs, for like the liver, for instance, are going to be in 3 of these regions. So it's important to remember, going into quadrants, we may get focused, oh, this is a spleen injury. However, there are 4 other organs right around it that it could be as well. So if we're looking, liver you'll see in the right hypochondriac, the epigastric, and the right lumbar region. Intestines we'll see throughout. Spleen will be in your left hypochondriac, as well as a little bit to the epigastric region. That's just some examples. I'm not going to go through where every organ is exactly located. I'll spend a little more time on the big ones that we talk about later. Lumbar, abdominal, and lumbar muscles. The main takeaway from this is going to be that the soft tissue of the abdomen, including the muscles, are going to provide the majority of your protection for the abdominal cavity. Obviously, the ribs do provide protection, but they're not going to cover the entire abdomen, especially the lower half. So, as you can see how the muscles are overaligned here, your rectus abdominis running almost vertical, external and internal obliques kind of running in opposite directions around, and then your transverse abdominis running more horizontal. The way those overlap, they're allowed to dissipate forces, meaning most muscular injuries to the abdomen are relatively minor. That's not to say you can't get severe injuries or internal injuries. That's why we're here today. So it's good to remember that, but that's going to provide a lot of protection right there. In the lumbar, kind of the same idea, not to the same extent. You have some bigger muscles like your latissimus dorsi. You have the smaller muscles of the spine that are there to protect and stabilize that. You have your thoracolumbar fascia, which will provide some protection as well. So the abdomen is really going to be where the forces are dissipated, but you're going to see that as well. These injuries can occur from the front, the side, the back, any of the above. So we continue on our anatomy overview. Blood supply, arteries, your abdominal aorta is obviously going to provide most of the blood to this region. We have a few branches of that, the parietal and visceral. You'll have your inferior phrenic innervating or supplying the diaphragm, lumbar supplying the major muscles of the back. Your renal will supply your kidneys, and inguinal will provide the reproductive organs. You go down to the next one, the celiac trunk. The celiac artery there is going to supply your foregut. The foregut is going to be defined as parts of your esophagus, stomach, parts of your duodenum, pancreas, gallbladder, and liver. Your superior mesenteric is another major artery. You're supplying the midgut, which is defined as the remainder of duodenum not innervated by the celiac artery, ilium, cecum, ascending colon, and proximal transverse colon. And then your inferior mesenteric, supplied by the is going to supply the hindgut. That's the remainder of your transverse colon, descending colon, sigmoid colon, and rectum. On to the veins. There's obviously more arteries and veins that I'm mentioning. I'm trying to give us a quick refresher so that we can spend a little more time on the recognition stuff of these injuries. So you have something like the portal vein, which we'll talk about again when we get to the liver, transporting blood from the stomach and the intestines to the liver. You have your inferior vena cava, transporting most of the blood from this area back up to the heart, the right atrium. And then vertebral plexus, they're going to be valveless, work on the respiratory process. During inspiration, venous return will increase. Blood is going to flow up through the vertebral plexus and out through the thorax, and the opposite is going to happen during expiration. We go on to abdominal nerve innervation. Thoracoabdominal nerves, it's going to be the ones that supply a majority of your abdominal and thoracic walls and the muscles and skin of that area. So those are going to be your important ones. You can also see in this picture here, hopefully it'll show you what number the nerves is being innervated by. Not incredibly important to know exactly, but we need to have a general idea and be familiar with these kind of injuries. So if you look at the phrenic, that's going to innervate the diaphragm. That'll come up again when we're talking about referred pain. Anterior and posterior vagal trunk is going to come off the vagus nerve. That, along with the thoracic splanchnic nerves, are going to be part of the sympathetic nervous system, meaning they're sympathetic and autonomic nervous system. The cool thing about the thoracic splanchnic nerves, if I'm saying that correctly, is the greater and lesser actually have fibers that will control the enteric nervous system. You may be familiar with the enteric nervous system, sometimes referred to as a second brain. It's in the gut. It's made up of about 500 million neurons. For comparison's sake, that's 1/200th of what the brain has, but it's 5 times as many that's found in the spinal cord. So it's a very complicated and complex area. Although this is innervated by the autonomic nervous system, it actually has the ability to operate independently of the brain and spinal cord. So it can control the reflexes of the GI tract, peristalsis by controlling motor control of the abdominal muscles. It tends to use over 30 neurotransmitters. Many are going to be the same ones we see in the central nervous system. And then 90% of serotonin, 50% of dopamine, they're actually going to be found in the gut. So this is just some background information, but kind of adding to the complexity of this region. As we'll see when we get to the injuries themselves, they can often be subtle and difficult to diagnose. But we also have this important autonomic nervous major division here. All right, so that was a quick anatomy that I kind of ran through, but in terms of protecting the abdominal cavity, like I said before, the layers of muscle, fascia, and skin are going to be our main source of protection. Again, that ability to dissipate forces really alleviates or makes more minor injuries for muscle contusions. That being said, just because they have a minor contusion doesn't mean they're going to be able to continue playing. It may be to have enough discomfort and limit their ability to perform. So that's something to be aware of. Ribs are obviously going to provide protection to the abdominal cavity as well. Organs like the spleen and the liver, fairly well tucked away behind there, provide some protection. They can obviously be injured either with a rib injury or separate. And then you look at the hollow organs, those are going to be things like your stomach, intestines, anything that's hollow with fluid or air in it. And they can absorb impacts, stretch, and return to their normal shape, meaning they're not usually injured through blunt trauma. However, how these will happen are they're really sensitive to pressure differences. So big difference between the pressure in the intra-abdominal area, and then they might get a rupture or a perforation there. You can also have something, a deceleration or a shearing force, where the body is suddenly stopped, the organs tend to keep moving, and you can get a tear that way as well. Okay, so moving on to a general overview of types of abdominal injuries. So these are going to range anywhere from minor, getting the wind knocked out, to contusions, to severe, where they'll have internal bleeding and loss of function. So the more basic ones, simple that we see all the time, are going to be our contusions and somebody who got the wind knocked out of them. It's going to be your temporary spasm or paralysis of the diaphragm. We've seen these all before. They're going to be caused usually by a blow to the abdomen, maybe falling onto a hard object like a ball or the ground. Your patient will present complaining of pain, acute shortness of breath, maybe leading to anxiety or panic. Our role, calm them down, get their breathing under control, so we can get them off the field, evaluate them further. As we'll see later, these injuries, you'll often get the diaphragm spasm as well as some internal injuries, so it's important to not just assume that this is a minor injury, but to do a little more evaluation. We'll go through that in a little bit. Back to our muscle injuries, just like anywhere else in the body, we're going to have our contusions, strains, and overuse. Overuse injuries you may see more in throwing athletes, but any athlete, bending, twisting, you're going to get muscle injuries to this area, either from use or from trauma, blunt trauma. We're going to do our normal resting, reducing inflammation, and then stretching and strengthening as appropriate. One thing you can do when you're doing your exam, determine if the pain is muscular, have them do a partial sit-up. If it hurts as soon as they activate it, it may be muscle, not something underneath. But again, these injuries, as I haven't even got to that yet, but they're going to be complex, and it's going to be sometimes difficult to identify. Get to skeletal injuries. The reason this slide is important is because you will often get a differential diagnosis of some of these rib injuries or sternum injuries when we're dealing with these internal trauma. And it makes sense as it's going to take a large force or impact to hurt these internal organs. So if you're also likely to get a rib injury, or it may look like there's a rib or skeletal injury going on. So it's possible to get both, one or the other. And another problem is that a lot of times the symptoms of these injuries will be masked. So you may have the pain of a rib fracture, you have pain, nausea, maybe some rapid shallow breathing. And that's kind of similar to what we see in internal injuries. So a lot of times we may be focused on the superficial, maybe fractured rib, and we're not looking deeper into the internal organs part of it. Like I said, ribs are going to be really common for differential diagnosis. Side note, any fracture to the 8th or 12th ribs could potentially lead to a puncture, damage to the organs, so it's something to be aware of. Our sternum and xiphoid process is going to end kind of right before what we consider the abdominal cavity, right superior to it. But there again, read case studies of being tender right over that area, and it's all going to depend on where they were hit, how much impact there was. When we look at the pelvis and iliac crest, it's going to be probably more related to kidney injuries. Kidneys tend to hurt, or when they're hurt, they have a wider area of pain, so you may confuse the two. Or they may have had a collision where they do get that contusion on the iliac crest as well as an injury to the kidneys. See in our picture, our friend Gronk there, who had a bruised sternum a season or two ago. Obviously a man that big can be injured, so can our athletes. So herniations, these aren't going to be necessarily from trauma, not something we will see, but it's something we commonly see in our practices. So intestines protruding through your abdominal wall, usually caused by an increase in intra-abdominal pressure, either due to a muscle contraction or some external force. You may have a palpable mass at that site. As you look at the inguinal region, is probably going to be the most common one that we see, but any of those sites there are possible. Men are going to be slightly more at risk than women for herniations. And then if you do suspect a herniation, they obviously need to be referred and evaluated. The longer that intestine is protruding through the wall, the higher the risk of necrosis and eventual death of that part of the intestine. So here's the reason we're all here today, I suppose, is internal injuries with lacerations, ruptures of the organs. So just so we're using the same terminology, in my presentation, laceration and ruptures are going to be somewhat similar in that laceration is going to affect a smaller portion of the organ, while rupture is going to affect most of, if not all of it. Kind of similar to the grading system we see with muscle injuries or something like that, a few fibers being grade 1 up to grade 3. This is obviously on a more grade 5 system, I believe. So mechanism of injury, it's going to depend on the organ. If it's a solid organ like the spleen or the liver, you're looking at usually blunt trauma causing it, either to the abdomen or the side. Also the deceleration shearing force would be possible with the solid organs. So again, the body comes to a sudden stop, the organs tend to keep moving. You may see injury at the blood vessels, so vascular injury might tear, or some point where it is a fixed attachment either to the ab wall, rib cage. It may actually tear at that point as well. I'm going to go over the signs and symptoms of each organ when we get to it, so I'm not going to do it now, but it's important to realize that these are not always going to present as traumatic injuries. They are often subtle, and they can be delayed in their onset. Some of these symptoms can not appear for days or even weeks, depending on the injury or the organ. So it's not something we're always going to catch with our first initial exam on the sidelines. And the next slide kind of goes through that. Some stats that I found that approximately 50% of initial exams are going to be negative, even for athletes with significant abdominal trauma. And the next one, with 20% of patients with blood in their peritoneal cavity already have initial negative exams as well. So this is a little alarming, as both of these groups of athletes or patients need to be evaluated. The one with bleeding in their abdominal cavity already, those people could deteriorate rather rapidly. They're going to have to get out, you have to watch for shock. The other people are most likely going to have some bleeding, or maybe not, but it's important that they're going to be evaluated as well. So the fact that we're missing this many is pretty alarming. They have, let's see, look at this here. The reason why is when we see them, we're seeing them a few seconds, a few minutes after an injury occurs, especially if it's on the field. And these injuries almost are never going to present the symptoms that quickly. Obviously, if you have a full rupture immediately, they're going to present with more serious symptoms right away. But the more minor lacerations, things of that nature, we won't see right away. And some of the more obvious symptoms take hours, maybe even days to present. Picture here, this is Andrew Luck of the Colts. 2015, make sure it was 2015, yes. He lacerated his kidney on this play. He also tore an abdominal muscle and injured his shoulder and ribs. So he was having a bad afternoon. He actually, this play happened on like the first or second play of the fourth quarter. He ended up staying in and finishing the rest of the game. And it wasn't until the next day that they found out he had a lacerated kidney. So this is obviously an NFL team and their star player with a medical staff and access to imaging probably in the stadium or at least at a nearby hospital. And they didn't find this till the next day. So, like I said, it's not always something that we can see right away, and it's something that we may have to continue for a couple of days to make sure our patients are improving. Side note, the team originally said he'd be out 2 to 6 weeks with this injury. I read an interview from a local paper 5 months later. He still wasn't feeling 100%. He obviously had multiple injuries, so it's going to slow down his recovery process. So that's something we can expect. If there are this big of a collision, you might have multiple injuries. The recovery process might be a little slower. One thing I guess I can say, just the take home from this, is follow-ups with your athletes. You may do that initial exam. They may be negative for everything. Check with them again in 20 minutes or so. Check with them after the game. Have somebody check in with them at night. If you're working at a high school, talk to the parents. If you're working at a college, maybe they can contact you. Maybe you can have a teammate or a coach check in with them just to make sure they are doing fine. These are some tips, techniques that we can use when evaluating these injuries. Some we may do on the sidelines, some may be more athletic training room. Some of these we may not do at all, depending on what you prefer. So the first one, inspection, I think is a good one that we all probably should do. Visual inspection, patient laying supine, you're checking the abdomen for abnormalities. Things like scars may show you that they have a prior history of an injury, or that maybe they had a surgery to remove an organ when they were younger and you don't have to worry about that at this time. Contusions, abdominal distension, or bloating may occur later on down the road, so something we may not see initially. You'll look for asymmetry side to side while they're breathing. You'll also look for breathing that's rapid and shallow. That tends to happen with these types of injuries. I'm going to come back to this slide. I just want to show the next picture on the next slide, which is Cullen's sign and Gray-Turner's sign. Both of these are superficial bruising. Cullen's sign is of the umbilicus, Gray-Turner's is of the flank. Both can be used to predict acute pancreatitis or bleeding, general bleeding in the abdominal cavity. They usually take 24 to 48 hours to appear, so initially we may not see these. This may be something that our patient comes in a day or two and they have this. That's a sign that they have had abdominal bleeding. These actually used to be one of the main tools for diagnostics used in hospitals. Now with all the advances in imaging, we usually catch these before these appear. However, if your patient presents with these, that is a reason to get them checked out rather quickly. Auscultation, if you're going to plan to listen at all to the abdominal cavity, you need to do palpation last. As you're palpating, you're likely to create sounds while you move things around. So things you're going to be listening for during auscultation are your normal clicking, gurgling of the bowel sounds. You may hear a couple, you may hear a few dozen every minute. The absence of bowel sounds is a reason for a referral. However, to be considered absent, you need to listen for 5 continuous minutes, which is obviously a long time. Percussion can have some use because it can tell you whether there's fluid or air in the abdominal cavity. It's usually used to determine the size and density of organs. So it takes a little practice, experience, as you're going to have to know where each organ is, what the sound should be, and then if there is something going on, that abnormal sound is occurring. Go down to palpation, which is our go-to technique most of the time. So you're going to start with initial light palpation, all 4 quadrants, checking for muscle or peritoneal lining injury. If they do have pain, it may prevent you from doing much deeper palpation. You'll have to modify your assessment. So the next step after that would be doing deeper palpation, about 3 to 4 centimeters. doing all 4 quadrants, but then focusing on the quadrant or the organ that you think may be involved, whether that's the liver or the spleen or anything else. So, a little slow, so let's get that next part. So red flags, these are some general ones. You'll see a lot of these again when we get to the specific organs that are damaged. Kerr sign, your classic referred pain to either shoulder. That's one of the more obvious and classic signs of a ruptured or lacerated internal organ. The reason you get pain in your shoulder, the contents of the organ are going to spill into the abdominal cavity, aggravate the diaphragm. The phrenic nerves that we talked about earlier are going to come up into your brachial plexus, and that's where you'll get that referred pain. Vital signs, and you'll definitely see these again, I'm going to stress this a few times. It's probably going to be one of your earliest and most reliable indicators that something serious may be going on. In terms of heart rate, the patient's going to present with tachycardia, so a rapid heart rate. So it's going to be important to give them appropriate rest. They've obviously just been playing a sport. You need to get their heart rate down to what their normal level would be. It'll also be important to know their baseline. Otherwise, it'd be hard to tell whether their heart rate is elevated. Respiratory rate, 12 to 20 breaths per minute is the normal. Internal injuries, they're usually going to have rapid, shallow breathing. That doesn't necessarily resolve like you would expect, maybe with a diaphragm spasm. And then blood pressure, a drop to low blood pressure, anything below 100/65 is considered low BP. That's going to happen later on in the process, but that's a sign that significant bleeding has occurred in the abdominal cavity. Something interesting I read in a few places, the presence of muscle guarding alone is enough to require referral. The reason for this is anytime we're having muscle guarding, our body's trying to protect something. And the thought is because there's so many important and vital organs in this area, if something is damaged, we need to get it checked out. I think that's kind of more. You can kind of make your decision on that. If you have other symptoms as well, like rebound tenderness is usually going to be indicative of a serious injury or at least peritoneal lining injury. But again, you have a couple other symptoms, I think that would be a reason to refer for sure. You're going to ask your patients to monitor urine, feces, and vomit for any blood. Any blood in any of those will be a red flag for you. Signs of internal bleeding, you'll see again, I have it on the other slides, specific internal injuries. Kind of looking similar to shock, low BP, nausea, vomiting, decreased alertness. And then any patient suspecting of having an internal injury should be instructed not to eat until they're evaluated, eat or drink. Obviously there's a problem with the GI tract that can make things worse. If they do end up needing emergency surgery, any kind of, that could complicate matters as well. So this story, I think a lot of us from around here are probably familiar with. 2001, Drew Bledsoe on the Patriots was hit by Mo Lewis on the sidelines. And this quote is from Sports Illustrated in 2016, so 15 years later. The reason I include this, I'm not going to talk about hemothorax today, we're talking about abdominal injuries, but the way Dr. Gill describes it, who was the team doctor at the time, of seeing something over and over again and we're getting into this repetition, but sometimes there is something more serious going on that we aren't always prepared for. So quick overview of the events here. He was hit, he came out of the game, he was actually allowed to return to the game for a series after being evaluated. He came off the field, he just couldn't get comfortable, didn't feel right. They took him back to the locker room for further evaluation. Back there, they really couldn't find much wrong with him. So they actually were going to let him go home. Somebody was there to give him a ride. Whoever decided maybe we wait, let's evaluate you a little bit further. Eventually, he started getting referred pain into his shoulder, so they expected a ruptured spleen. They also found out he had a rapid pulse and rapid shallow breathing. So they sent him to be checked. They did imaging, the spleen was fine, and everything in the abdomen was fine. What they found was he had torn a blood vessel behind one of his ribs. It had 3 liters of blood in his chest drain. This could have killed him if they didn't catch this as early as they did. And I just think it's important to, I like the quote and what he says, because sometimes we do need to think outside the box. And this hit obviously led the way for Tom Brady, which is, oh wait, if I can get that into my presentation. It is Sunday after all. So now we're going to go, oops, one too far. We're going to go into the spleen, specifically with the spleen, the liver, the kidney, and then a couple other quickly or injuries we might see. So, the spleen, anatomy and function-wise, we got a fist or shoe-shaped organ. It's going to be located in the left hypochondriac and partly in the epigastric region in your upper left quadrant there. In terms of where it comes in contact, it's going to actually touch the anterior surface of the left kidney, part of your splenic fixture of the colon, fundus of the stomach, and the tail of the pancreas. The only reason why I say this is, again, we may be thinking spleen injury. There are 4 organs that it touches. Any one of those could be damaged as well. So it's important to recognize there's a lot going on in this region. Function-wise, it's going to filter blood as part of the lymphatic system. Red blood cells come into the spleen through narrow passages. Any healthy ones go right through. Any damaged old ones, they're going to get trapped or caught in there. And then the white blood cells are going to break those down. Those are your phagocytes. Anytime there's a harmful bacteria, virus in the body, they're going to create additional white blood cells. Those are your lymphocytes. And it's also going to control the amount of red blood cells and blood storage in the body by storing red blood cells, 8%. The reason the spleen actually tends to bleed so much with injuries is because of it storing red blood cells. And it filters 10% of the blood supply every minute. So there's a lot of blood coming and going from this area, and the spleen will tend to bleed a lot into the abdominal cavity, as you can see on the next slide. It is the most commonly injured, and it is the leading cause of death with sports-related abdominal injuries. You're going to account for about 10% of all abdominal injuries. It doesn't seem like that high of a number, but when you think about all the other organs that exist in there, in the abdominal cavity, and the fact that rupture is the far extreme, the worst case scenario, it actually does seem like a fairly high number to me. MOI is going to be a direct blow to your left upper quadrant or left lower chest wall, or you could get some deceleration shearing forces like I mentioned as well. People at increased risk, contact collision sports, obviously, higher impact collisions, you're going to be more likely to injure this organ. Anybody enlarged inflamed spleen, I think we all are familiar with, are not going to be able to participate in sports because they are much more vulnerable. You can see the outline in this picture. It becomes very vulnerable under the rib, but it's also going to press up against that rib cage, so any shot from the side may also cause injury. Signs and symptoms, you'll have pain in the left upper quadrant. Tenderness with palpation. You shouldn't be able to palpate the spleen unless it's enlarged. However, you're going to have general soreness in that area. You're going to have to determine whether it's a rib injury, whether it's something else, muscular, something going on underneath. Kerr's sign is our classic, most obvious sign that a ruptured or lacerated spleen may have occurred. You can get that pain into your left shoulder with rib injury, spleen injuries. It's likely to see muscle guarding, rebound tenderness. Again, those with other symptoms may be reasons for referral. Abdominal distension or bruising will probably occur later on down the line. Another one I added, normal body movements like sitting and walking causes pain. A common theme here is that they can't get comfortable no matter what they're doing. They can't really sit, they can't lay down, stand, whatever they're doing, there's just a constant discomfort in that area. Vital signs, like I said, I'm going to mention these a few times. Rapid pulse with tachycardia. The pulse volume may actually weaken a little towards the end, later stages. Rapid shallow breathing, it doesn't resolve. And then your diminished low BP being one of the late signs. And signs of internal bleeding again. If you have patients looking like this, they need to be evaluated sooner rather than later. So I just went through all those symptoms and signs we might see that think, oh, should be fairly easy to recognize. But then we get to a case like Alex Smith, Chiefs quarterback, 2014. He lacerated his spleen in the second to last game of the year. And as you can see from his quote, this injury didn't prohibit him athletically, he said. He had some nausea coming and going, but there was a bug going around the team, so he didn't really think much of it. He ended up practicing, he hurt himself on Sunday. He ended up practicing the Tuesday and Wednesday of the next week. He said he felt great, running around and throwing. Eventually, he had a little just discomfort that wouldn't go away. The doctors pushed him and pushed him. Finally, he goes, he had a lacerated spleen. It was the second last game. He missed the last game, was back for the next season. But just showing how differently these can present. This was probably 3-4 days later before they caught the fact that he had a lacerated spleen at all. Immediate management. If we have a rupture, you see the bottom right picture, that's really bad. I don't think we'll see something. That's more car accidents and stuff like that. But if you have a really bad rupture, they're going to be in severe pain. They're going to see some of the obvious signs and symptoms. But just be aware for some of the more minor injuries, and it's possible for the severe ones, this could be delayed hours or days. Something I read that was interesting was that a normal physical exam does not rule out the possibility of a splenic rupture. And that puts us in kind of a tough place, as that's normally what we do, is we like to do tests and things to rule out injuries so we can kind of narrow down what may be going on. But in these situations, it's not going to be reliable enough, especially initially, to determine whether there was a splenic rupture or laceration. So follow-ups, and if you have any doubt, have them checked. Worst cases, they're not going to have bleeding and they'll be back, okay? If you do suspect a laceration or rupture, they obviously need to be evaluated and imaged to see what's going on. If you have somebody going into shock or signs of shock, I think EMS ambulance makes the most sense. If they're stable, and you can get them to the hospital in another way, I think that's fine. Emergency action plan, whatever makes sense for your institution, that is fine. So in terms of hospital care, they're going to do imaging to determine the extent of the bleeding. They'll do blood tests to see if there are any infections or when the bleeding may have stopped. They're going to have to remove with the spleen a lot of pooled blood and swelling. And then they'll either do surgery to repair the organ, or if it's too bad, they'll just remove it altogether. Returning to play, obviously anybody with mono or an enlarged spleen from other blood disorders, they need to be held out of sports until that is resolved, usually a few weeks to a month or so. Looking at the more minor splenic contusions and lacerations, restricted activity for 2 to 3 weeks. We'll return to play in about 6. And then splenic ruptures, you're looking 3 to 6 months maybe of restricted activity. I did read a study that showed most splenic ruptures, 84% of them had healed at the 2.5-month mark. So the 3 month is probably about right. All of these are going to be a little bit different. It's going to depend on the severity of the injury, what surgical procedure needed to be done, and then the age of your patient. Is it worth the risk of them coming back sooner rather, or taking some extra time? If you have your spleen removed, you may return a little quicker because there isn't as much tissue that needs to be healed. And you can live and play without a spleen. You're just going to be more at risk for infections, so you'll have to probably take medications or vaccinations or something like that. So that is it for the spleen. Moving on to the liver. It's going to be the heaviest and biggest organ in the body. Weighs about 3.5 pounds, located in the right upper quadrant. In terms of location, it's going to be just below your diaphragm, to the right of the stomach, and overlies the gallbladder. It's made up of 2 main lobes, right and left, and those lobes are then broken up into segments. They break down into lobules, small ducts, larger ducts, and those form the common hepatic duct, which is important because it's going to transport bile to the gallbladder and the duodenum from the liver here. 2 major arteries, or blood vessels I should say, to discuss. Hepatic artery is going to carry oxygenated blood to the liver. It's also going to supply the stomach, duodenum, and pancreas. And then the portal vein, which we talked about earlier, carrying blood from the GI tract, gallbladder, pancreas, and spleen to the liver. Approximately 75% of the blood the liver receives is going to come from the portal vein. The blood in this vein is going to be rich in nutrients from digested foods. The liver is going to process that out, store anything that it is good, distribute that as necessary, and then it'll also pull out any toxins that may be found in there as well. Next up is going to be liver function. This is not an all-encompassing list. I was shocked when I was reading that the liver may have something around 500 functions in combination with other organs and systems. So we don't need to know all of those, and I don't have the time to go through them. But these are the main real important ones here. Is you're going to filter blood from the GI tract like I was just talking about. It's going to excrete any harmful or waste products either through the urine or feces. And then it's going to be produced bile, which is used in the digestion and absorption of fats. The liver is the main site for drug metabolism, which is obviously an important function. We may see athletes who maybe have some liver dysfunction when they're on medications or something, so that's something to be aware of. It's going to produce cholesterol, which helps carry fat. It's going to produce several of the proteins found in the blood plasma. It can store and release glucose and iron as needed. Then it can help regulate blood clotting and fights infections as well. It also stores all kinds of substances, vitamin A, vitamin D, vitamin B12. Some of these it stores enough for a couple months, sometimes for a couple years. And then there's currently no artificial organ or device that can mimic all of the liver's functions. Liver dialysis is used and still studied extensively, but obviously if there are 500 functions, it's unlikely that all of those are going to be able to be brought back. Liver is going to be our second most common internal injury. MOI is going to be that picture, which is a direct blow to the right upper quadrant or right lower chest wall. The right lobe is going to be actually more likely to be injured, as it's a little bit bigger and it presses up against the rib cage, making it more susceptible to direct blows. So we move on to signs and symptoms. You have pain in your right upper quadrant. It's usually described as sharp. So that is why you'll often get a potential rib injury as a differential diagnosis. Or you could have a rib injury and a liver injury at the same time. So if you have referred pain in your right shoulder, this Kerr sign, usually it will be on the right shoulder this time. Muscle guarding, abdominal rigidity of the ab wall, interior ab wall, are all signs that something may be going on. Oops, went too far. Bruising and swelling later down the road. Body movements, again, just cannot get comfortable. They can't find a position that makes them feel okay. Vital signs of tachycardia, rapid shallow breathing, which I think I'm hammering home enough today, and then diminished blood pressure, which is a late sign. Diaphragm spasm I have on here, and it's not a this is not a sign of a liver injury. However, because of its proximity to the liver, that's often how these athletes will present on the field, is with diaphragm spasm at first. So I just want to go quickly. I know we have a case study coming up a little later, so I don't want to take too much, but there are two different cases of what symptoms you might see and how these injuries can be kind of similar. So a football player who was hit had initial diaphragm spasm and pain in his upper right quadrant. He did vomit once on the field. Whether that was related to the diaphragm spasm, I'm not sure. Upon further evaluation, his ribs were tender, but he had no deformity. There was no rigidity or muscle guarding. His blood pressure and pulse were within normal limits, and his lungs and bowel sounds were clear and normal. The thing that gave this away is eventually he had that rapid shallow breathing that didn't resolve, so they sent him for further evaluation. The next case study was a volleyball player who was kneed in the chest or the abdomen. Again, initial diaphragm spasm, pain in that upper right quadrant, labored, rapid shallow breathing, and nausea on the court. We did further evaluation, and she was tender over her ribs and sternum. Was pale, sweating, hypersalivation, looking like signs of shock or internal bleeding, and then described the feeling of having a bowel movement or feeling like she was having a bowel movement. Both of these patients both had approximately 3 centimeter laceration to the liver. The volleyball players was slightly worse, like 1 centimeter more, I believe. But the volleyball player, I think, is the more obvious. We would jump to that. I think something is going wrong. The football player, not as much. They didn't have really the symptoms other than the breathing issues. Everything else was within normal limits. So kind of just showing the difficulty, again, that these injuries may possess. Okay, liver, immediate management. You may experience a diaphragm spasm like we were just talking about, so you have to deal with that and then determine if there's anything else more serious going on. Same deal as before, where if you're expecting a liver injury, they need to be checked. So they're going to shock further down the line. They need to go sooner rather than later. Either way, we want to get them there as soon as possible. Imaging-wise, we will determine the extent of the injury, blood tests and CBC to determine any infections or when the bleeding will stop. The liver is not going to bleed as much as the spleen, so there won't be as much need to remove pooled or blood and swelling. It also tends to heal on its own, which means surgery isn't always necessary, especially for minor injuries. The liver can obviously regenerate, so they can remove a large portion of it, and it will grow back to its original mass and function. It actually doesn't grow to the same shape as it did before, so it's not like a full regeneration, but it restores all of the functions. Slide there. Okay. Returning to play, you're talking minor to moderate liver laceration, maybe 2 to 4 months. Severe injuries, maybe a little bit longer, up to 6. There's debate over whether people should have a normal CT scan at the 3 to 6 month mark before they return to play. Obviously, some people prefer to not have extra imaging done, so that'll be up to the doctors and medical team working on them. A good sign that things are healing is the liver enzymes normalizing. That's usually a good indicator. And then expect light activity for 3 months, gradual return, full return to play. I don't think I mentioned this during the screen, but during light activity, they're going to be extremely limited in what they're allowed to do. They may be allowed to eventually get on a stationary bike for cardio purposes, probably not with much resistance at all. They'll definitely have a limit on how much they can lift. I have a case study I'll go over later where they weren't allowed to lift more than 20 pounds for 2 months, which is obviously going to affect your activities of daily living. So it's all things to consider. And then if you have someone out 3 to 6 months, obviously with unrestricted activity, it's going to be kind of like they're starting from scratch when you get them back to getting their fitness levels back up and strength. So we'll move on to the kidneys now, which is my last major one. Quick hitters. So you get 2 kidneys, obviously, on each side of the spine. They're going to be located. They consist, of millions of microscopic nephrons. You can see the picture of the nephron there, kind of how the blood filters in and out. In terms of function, the blood is going to remove, or the kidneys are going to remove waste from the blood. Things like urea and ammonium, they will excrete through the urine. Through the removal of the waste, it also is going to reabsorb water, glucose, and amino acids, which is going to help regulate the electrolyte fluid balance, as well as acid-base homeostasis of the blood. Produces an enzyme called renin, which is going to help regulate blood pressure, and then it produces hormones calcitrol and erythropoietin. The kidneys are the 3rd most common blunt abdominal injury. I believe it's the 4th most common overall, as the intestines are unlikely to be hurt through blunt trauma. So as you can see in this picture, the most of the kidneys are protected from by the ribs. However, the inferior poles are slightly inferior, making them a little more susceptible to direct blows. So MOI, you're looking at most likely a direct blow to the back side. However, you can get it from the front in the abdomen as well, compared to kidneys with a big enough blow. Shearing and deceleration forces that we've mentioned are also possible here. Children, again, are going to be more susceptible. Some of the issues I mentioned earlier, having less fat and muscle around the kidneys for protection, their organs being a little bit larger compared to adults, and then the kidneys sitting a little more inferiorly from that rib cage, making it more vulnerable. Contact collision sports, so the football, hockey, boxing are probably the ones we're going to think about most. However, there's a pretty high number of incidences in sports like horseback riding and gymnastics as well from falls. And the most commonly, in ERs, the most commonly seen injury from these are from biking, skiing, snowboarding, so some of those recreational activities. Signs and symptoms, you're going to have most likely low back pain. Kidneys, when they're injured, tend to be dispersed over a wider area. So if you have localized pain, it may be more of a rib involvement. You could also get pain in the abdomen, not necessarily going to present always in the back, adding a little difficulty in this diagnosis. The two major and obvious signs that there's a kidney injury is going to be blood in the urine, and then a decreased urine output or inability to urinate. The problem with that is these don't help us a lot when we're doing evaluations on the sidelines. They're not going to have gone to the bathroom most likely before seeing you. It's not something that I wouldn't personally tell somebody they have to go to the bathroom to check. I think it's something that you will eventually, they're going to have to go, and that's when you can have them check. Obviously, if you have other symptoms that are leading you to think that, you don't even need to know if there's blood in the urine before they get evaluated, but if there is any blood in the urine, whether it's easily visible, it can be microscopic, that's really only picked up through tests, they need to be checked. Bruising, swelling, you have that gray Turner sign I showed you earlier on the flank, that would be common with kidneys. Muscle guarding and abdominal rigidity actually usually happen on the anterior ab wall, not so much in the back. But again, it kind of depends on everybody and the type of the injury. Vital signs, tachycardia, rapid shallow breathing, you can get it. And then signs of internal bleeding again, similar to shock. So, like I said, this can be a little difficult only because we may only be getting pain as a symptom. We may not get the muscle guarding, we may not get bruising and swelling for later. And our vital signs can give it away, but our classic symptoms or signs are something that's going to happen probably later on when you're inside. You're obviously going to tell them to check their urine on their own, either way, even if you don't suspect that they had the appropriate MOI. So current recommendations are going to state all children who sustain blunt trauma and experience blood in their urine need to be evaluated. I would drop the children part and listen to everybody should go. I think if there's blood in the urine from trauma, then there's something going on in the kidneys. You're going to do our normal activating EMS or EAP, whatever makes sense for you. In terms of imaging, we'll do CT scan, ultrasound, we'll do a urinalysis. You'll probably have to remove any pooled blood or swelling, which will occur, and then they'll have surgery, which is fairly rare, actually, for the kidneys. So if they have a minor injury, microscopic blood in the urine, probably they'll go get checked, they'll have a couple days of observation. That's probably about it, maybe a visit to a urologist. The more serious injuries, you're looking at overnight hospitalization, antibiotics until the bleeding stops. And if it won't, conservative treatment, then surgery is an option. With almost all of these injuries, they're going to attempt conservative treatment first, medications and other things to stop the bleeding. It's only then when they cannot get it to stop that they'll do surgery. Returning to play, the kidneys are usually going to heal in about 2 to 3 weeks from minor injuries. You're likely to see some doctors and other things say they should be out for about 6, depending on the age of the patient, obviously. Severe lacerations and ruptures tend to heal in about 6 to 8 weeks. Maybe not the rupture part, but the laceration. Then maybe up to 6 to 12 months before they're allowed to return to contact sports. And there is debate over allowing people with one kidney to play contact sports. Obviously, if that other functioning kidney were to be damaged and they were to lose function, then they're going to be on dialysis for the remainder of their life. So that'll be coming out to the doctor, the patient, their family. Is it worth the risk of playing with the one kidney? And on the next slide, I have some stats on what doctors recommend in terms of that. So again, restricted activity. They're going to be not able to do much cardio. They're going to have serious deficits in fitness when they come back. You may see them hesitant to go 100% avoid contact depending on the age of our patients. Some may feel more comfortable wearing these protections. I read studies that kind of question the effectiveness of these. But again, if mentally it gets them back at first, then I think it's okay. NFL kidney study. They looked at all the cases of kidney injury in the NFL over a 20-plus year period. There were 52 cases, 49 of them coming from contact. So as you can see, what they found was it was 10 times more likely to occur during a game than practice, which makes sense. You have the average days missed here. All of these, the laceration has 60 days, contusion 15 days. Those are all in the very shorter end of that recovery process that I just talked about. But these are professional athletes. Obviously, they're going to be a little more quick to return them once the organ is healed than they will be with maybe college or especially high school or youth athletes. So returning an athlete with one functioning kidney, they also asked physicians that question in this survey. What they found was 61% said they would allow a pro athlete to return. It was split right down the middle, 50-50, on whether they would allow a college athlete to return, and then 60% would advise a high school athlete not to return. So kind of how we would expect pro athletes, they're probably going to let them take that chance if that's their career and they're making money. College, a little surprised at 50-50, and then 60% high school makes sense. Obviously these injuries are rare, so it's not just because they only have one kidney left that they're automatically going to get injured or anything's at risk, but they're going to have to make that decision, whether it's worth it for them. So a couple more and then I'll be done. I actually think I'm on time, which is good. So our hollow organs are stomach, intestines, colon, anything hollow, barren fluid. They're most likely to be injured through a rise in intra-abdominal pressure, either through muscle contraction or external force. It's rare that they're injured through blunt trauma, although possible, but 2/3 of those blunt traumas are going to be from car accidents, so a really high level impact and velocity. But they're very sensitive to pressure changes, as I was saying, so they can rupture or perforate that way. Signs and symptoms, especially if there's been leaking into the abdominal cavity, you're going to have severe pain, vomiting, fever, muscle guarding and rigidity, and then our CV signs will be present as well. What can happen, and what makes these difficult, they're not usually injured with blunt trauma because hematoma, it's going to form inside the wall of that hollow organ. Usually the body is able to reabsorb that without much issue. But sometimes that will actually rupture a few days, a week later, and that's when you'll get the leakage into the abdominal cavity. Pain could be just about anywhere since the intestines and all of these hollow organs are spread throughout. When you do have intestinal injuries, expect it to start as very mild, feeling almost like a cramp, and then it steadily follows a pattern of getting worse. Like I said, they're going to do conservative treatment, trying to get the bleeding to stop or leakage to stop. And then if that's unsuccessful, they'll do surgery to repair or remove part of that organ. There's not a ton of research out there on how long somebody would be out from sports when they have this injury. I think it's just kind of rare to see, so there's not a ton out there. But definitely expect restricted activity where they have a limit on how much they can lift for a while, as the pressure difference, the muscle contraction, especially if they repair part of that organ, it's going to be very susceptible for a while. And they're not going to want a pressure difference until it's completely healed. Appendix rupture. This is also very rare. Usually the appendix is going to rupture without trauma. Again, it gets bacteria blockage, it'll multiply, it gets inflamed, and it'll rupture. It's the normal mechanism. However, with the right blow, it is possible. So the right lower quadrant is where you'll get your pain and the mechanism of injury. Children are a little bit more at risk. I read a couple of case studies. Children brought in 3 days after the initial injury, an appendix rupture. I believe they were like bicycle handlebar injuries, if I remember correctly. Pain will start around the umbilicus and gradually shift to the right, where it will get more severe. In terms of missed time, people are back to their work school routine in a couple of weeks. Sports participation is going to be further delayed than that. But again, the appendix, they're probably going to remove it if it's inflamed or damaged, so you won't have that tissue that needs to be repaired quite as much. Last one of the day is, for me anyways, is pancreatic injury. So this is another really rare one, occurring in only 2% of blunt abdominal cases. Most of these injuries occur during stabbing or gunshot wounds. 20 to 30% of stab or gunshot wounds have pancreatic involvement, which is a lot. But we can get some blunt trauma. The reason it's not hurt too much is because it's protected so well from where it sits, so you need to have a lot of force to injure it. And what will happen is the pancreas actually gets compressed against the vertebral column. So car accidents, again, are going to be the main one, but you're going to have children, bicycle handlebars, or falling, or a direct blow like a kick might do it as well. It's very rare that the pancreas is injured by itself. 90% of cases involve another organ, and that can make things difficult because it's going to mask some symptoms of the pancreas being injured. In the grand scheme of things, if we can identify that there is any internal damage or organ problem going on, then narrowing it down isn't extremely important. However, especially with the pancreas, even in the hospital, it's going to be difficult for them to image it. Depending on what part is injured, they're going to have to use different imaging techniques, so that if you can point them in that right direction, it'll help. Another case where I read physical exam is not going to be reliable when dealing with pancreatic injury. Something to think about. The reason why 20% of patients are not going to report any abdominal pain initially. Rebound tenderness will only be present in about 10%. And what makes this really difficult is the pain actually improves over the first 2 hours, and then only to get worse by hours like 4 to 6. Is there anything else? Last thing I want to talk about is a little case study of a pancreatic injury in a soccer player. It was knee right. You're going to find right between the two upper quadrants. On the field or at the field, she only had minor discomfort and nausea. This team was on a road trip, so they figured she had fairly minor symptoms, so they could wait till they got back to campus. 3 hours after the game, they're having their team meal, and she was complaining of pain or discomfort while eating. Her symptoms were still fairly minor, so they were still 90 minutes away, so they said they could bring her back, get her checked near the school. By the time they got back, she had severe abdominal pain, vomiting, and abdominal muscle spasms. She was found to have a laceration on her pancreas and hematoma on the intestines. We get multiple organs involved there. She wound up having surgery. They removed 75% of her pancreas and performed a splenectomy, which they always do, and I don't know why. There was no issue with the spleen, but a lot of times they just take it out. I don't know if it's in the way or if they don't like it. I don't know why. I have a bunch of cases like that. You don't need your spleen, but it doesn't hurt either. While she was in the hospital, she did actually develop an infection, so she was there for 18 days. And then she was restricted to lift less than 20 pounds for 2 months. So that is a long time to affect your activities of daily living, never mind sports. She didn't begin running until 7 months after surgery, and then didn't return to soccer until 2 months after that. So, kind of almost like a year off. So, a pretty serious injury. Not one we see all the time, but there can be complications with the surgery in terms of infections. There can be other organs that they take out that are involved. So these can be a very slow process. And that is it for me. I have some references for images and regular references. And that's it. Thank you. Yeah, of course.
Can you live without the pancreas? Is it in with it?
No, the pancreas, so what they did is they took out 75% of her pancreas. So you'll need the pancreas for the most part, for normal functions and things of that
Does
nature.
that grow back or no? You just-
That's a good question. I don't know about the pancreas. Obviously, the liver does regenerates, but I think the liver is the only organ that really regenerates like that. So,
They're working on it.
okay, so that makes sense. So yeah, obviously at 25%, they must think it can give enough function to do what it needs to do. Right.
Do we have any other questions for Larry? All right, we'll have another chance to ask questions later on. We're going to take a 5-minute break. The server should be coming back if you want to order another drink. You can line up behind me for food because I haven't eaten yet. Our next speaker is Jim Scanlon. Jim received his Bachelor of Science in Kinesiology and minor in Psychology from UMass Amherst. He achieved his Master of Science in Athletic Training at Bridgewater State University and is currently pursuing his Doctorate of Health Sciences from Massachusetts College of Pharmacy and Health Sciences. Jim has been a licensed athletic trainer in the Commonwealth for several years and has had numerous clinical experiences. While he currently serves as the athletic director and head athletic trainer for Grafton High School, Jim has also served clinical roles at Roger Williams University, Brown University, Bryant University, and the Cape Cod Baseball League. His clinical expertise as a practicing athletic trainer has allowed him to work and volunteer his time for organizations such as the Massachusetts Youth Soccer Association, the New England Pro-Am Hockey League, and the Midsummer Lacrosse Classic. Jim also serves as an approved clinical preceptor for Bridgewater State University Athletic Training Program. He teaches part-time in the BSU Athletic Training Program in addition to providing guest lectures on topics such as diabetes, mellitus recognition, awareness, and management. Jim enjoys time with his friends, family, and dog Oakley. One of his favorite places to be is Conway Lake, New Hampshire. Without further ado, Jim Scanlon.
Thank you, Megan. Thank you, all the Precision staff, for having me out here today. It's an excellent opportunity to talk a little bit about a case study from an injury, internal injury, that I happened to see in my role at Grafton High School as the athletic trainer. Thank you also to Larry for a great presentation before me, really setting me up for success here. So thank you for that. Disclaimer quickly, again, I'm an athletic trainer. I don't really make a whole ton of money. I don't have any special sponsorships, no conflicts here with this presentation. The objective for today is just to present this particular case. It's a splenic laceration in a 14-year-old male ice hockey player. And the reason I want to do this, and I think the reason this fits in well with what we're going over today, is this particular student athlete presented with a really complex confluence of signs and symptoms that were consistent with multiple internal injuries. And I just want to go over some of that. So we know with ice hockey, obviously, high risk of injury. Collision sport, high impact. Some of these pictures just barely touch on the stuff that you can see in ice hockey, and as I'm sure most of us are aware. The inherent risk to ice hockey is a sport, high speed, high impact, and mobile boards. So blunt trauma is fairly common. Hard landing surface with the ice. The culture is a big one. So much like football, ice hockey, it's a hard-hitting culture. It's one where you're praised for slamming someone into the boards and recognized for causing injury. So a big part of this, and part of why I want to present this case with the 14-year-old student athlete, is the risk of injury has a lot to do with skill, strength, and age. The younger the student athlete is, the less strong they are, the less strength they have in the cervical musculature, typically less skilled than the older players. So these all lead to a higher risk of injury. Common injuries in ice hockey, again, as we all are familiar with, I'm sure. Dislocations and subluxations, fractures, lacerations, contusions on the musculoskeletal level. In terms of internal injuries, somewhat less frequent than musculoskeletal. One exception may be concussions, mild traumatic brain injuries. These are very common in high school sports, very common in high-impact collision sports like football and ice hockey. In terms of internal organ pathology, one study that I read actually said, based on a National Pediatric Emergency Department visit log, where all of the patients reported to the ED with sports-related abdominal injuries, about 50% of those sports-related abdominal injuries were splenic injuries. They did involve the spleen. So actually surprisingly common in terms of internal organ pathology. So to provide a little background for this particular case, 14-year-old male ice hockey player, visiting team, so I'm sure you've had at least one instance in your career where you're covering another school, another student athlete, someone that you're not familiar with, you don't know baselines, you don't know anything about them. During the game, this particular, oh boy, batteries are running low. There's a plug there. I'll go continue then. When it dies, it dies. So traumatic left shoulder / head impact with the side boards. So as is common in ice hockey, we had a student athlete who was on a breakaway heading towards the offensive zone, skating down ice, full speed, and caught an edge with his skate, went down onto the side. His momentum continued carrying him head first into the boards behind the net. This patient was side-lying, not really moving, and there was a brief lull in the action. The game stopped, the referee skated over and immediately signaled for me to come onto the ice. So I actually, before I continue on with that, I found a video that kind of sums up this injury. So this player right there, similar to that. This particular student athlete remained side-lying, and it was the left side of the body. So again, as you watch him go head first into the boards here, it was more left side, head and shoulder, but very similar mechanism of injury to that, to provide a little more context visually. So again, high speed, high impact, immobile boards, traumatic impact injury. Immediate response, as I came out onto the ice, again, that patient was side-lying. He was conscious, alert, oriented. He was denying any C-spine pain. When I did get to him, he was breathing, he was talking. He just remained face down, kind of in a heap on the ice. He said circulation, sensation were normal. As I went in to feel for radial pulse, it was present. He was able to move. What he did say initially was that he was having some left shoulder pain. Now, of course, high impact, my first thought is I need to get in, I want to palpate and see what's going on. What can I find upon initial evaluation of this left shoulder? This is unique because there were acute as well as gradual signs and symptoms. So acutely, as we're taking a look, I get in there, I get underneath the shoulder pads, he was having some moderate left shoulder pain and there was obvious palpable deformity. It felt as though his humeral head had dislocated anteriorly on the left side. Speaking with the coach, speaking with the patient, he did have a past medical history of left shoulder dislocation. This has happened before. So concerns for C-spine injury, concerns for internal injury, concerns for musculoskeletal injury. Again, conscious, alert, oriented, denying any C-spine pain. Palpation of the C-spine was negative. He was moving. And he was actually able to turn over.
There you go.
And sit. So anyway, where I left off. this patient, immediately after injury, going out on the ice, was presenting with some acute signs and symptoms of musculoskeletal injury. Right? C-spine was more or less on ice evaluation ruled out. Can never truly rule out, but any of the red flags were missing. A lot of what we were seeing was consistent with musculoskeletal injury secondary to that mechanism of injury. As I said, there was obvious deformity upon palpation under the pads on the ice. It did feel as though that shoulder was anteriorly dislocated. The patient did have a past medical history of this, so he was comfortable with sitting out and actually skating off the ice under his own power. And actually skated back to the bench with his coach, left me to shuffle across the ice nice and slow. But he was able to go to the bench under his own power. So a little more background on this. We got to the bench, performed some secondary palpation. We were able to get the jersey off, we were able to kind of get the pads off a little bit and take a look. And left anterior shoulder dislocation was confirmed, and there was no C-spine tenderness upon further evaluation. While evaluating, there was some mild massage to the left deltoid cap and some mild inferior traction of the left humerus, and the shoulder actually more or less spontaneously reduced on the bench. So the patient's shoulder did return to its normal anatomical position. However, I did make the decision to remove him from play from that point forward. Was denying any additional signs and symptoms, said he felt fine. His shoulder just hurt a little bit because of the dislocation, or so we thought. I decided to then do a concussion evaluation because of the mechanism. So he did go head first, high speed into the boards. He did look a little glassy-eyed. So performed the concussion evaluation. His pupils were equal and reactive to light. His eye tracking was within normal limits. He didn't have any nystagmus gaze, no outward signs. He was complaining of some nausea, some dizziness, mild headache, mild pressure in the head. And we know from Larry's presentation that these can also be signs and symptoms of internal injury, but not by any means uncommon for concussion, which is also an internal injury of the head. So at this point, our differential diagnosis is MTBI, concussion, and left anterior shoulder dislocation, based upon what we've determined so far. Heart rate is normal, respiration rate is normal. For all intents and purposes, this patient is presenting normally, complaining of mild left shoulder pain, moderate left shoulder pain, which is not uncommon following an anterior shoulder dislocation. Signs and symptoms began to evolve. So as I told the patient, you're going to remain out of play, I'll get you some ice, I'll put the ice on there, just stay on the bench, I'm going to return in 5 minutes to reevaluate. Come back in 5 minutes, he reports persistent nausea, persistent dizziness, moderate pain at the left AC joint. So the pain now has become more localized and directly over the AC joint. He complained he had some moderate pain at the left thorax and a new sharp pain, I have sharp here in quotations, and in the left upper quadrant region. So now the mind starts to shift and change gears a little bit and say, okay, thinking of that mechanism of injury, that deceleration, that high blunt force impact, it's possible there could be something else going on here. However, we're keeping in mind left shoulder dislocation and concussion. So here we have this constellation of signs and symptoms that are consistent with multiple injuries. And now this evolution of signs and symptoms and actually new symptoms that are presenting. Now the next step for me was to evaluate the AC joint, and in the back of my mind I'm thinking, this is perfect, pain at the left shoulder. If there was internal injury, Kerr's sign, as Larry discussed, referred pain to the left shoulder. How do we differentiate between dislocation pain, pain subsequent to AC joint injury, pain subsequent to internal injury, and referred pain? Throughout all of this, I noticed he was pale and diaphoretic. Again, he had just come off the ice from playing 2 periods of hockey. So is he diaphoretic or is he just sweaty from playing hockey? It's tough to tell. I don't know how he looks normally. He didn't necessarily look any more pale than he did when he came off the ice. But again, this is where your judgment comes into play with evaluation. His radial pulse seemed to weaken a little bit and became a little thready, but his distal capillary refill, again, was within normal limits. So as I'm feeling this, I don't know if this is normal for him. Looking at that distal capillary refill in his digits, completely normal. I decided at this point to bring him into the locker room for further evaluation, to try to get those pads completely off, further evaluate the AC joint, and further evaluate the abdomen, and to figure out what's going on here. There are too many conflicting signs and symptoms, and I'm not comfortable with just saying, sit on the bench with ice, and we'll just keep observing you. It was difficult at this point to assess his heart rate because of the weak, thready nature of it. It would come in, it would come out, it was really tough to tell. But his distal capillary refill still remained within normal limits. So 1 to 2 seconds refill in his fingertips, everything seemed, again, for all intents and purposes, normal. His respiration rate was, again, within normal limits. It was full, deep breaths, no concerns there. He remained conscious, alert, and oriented, and palpation at the abdomen and the shoulder remained largely unremarkable. As I palpated his left upper quadrant, there was slight rigidity and some tenderness. And the reason I say slight, and the reason that I say this with some hesitation, is because, to provide some more context, this student athlete was about 5'4", maybe 145 pounds, pretty diminutive in size physically, probably 0% body fat, so a lot of defined musculature. So as you're palpating, it was pretty firm everywhere that you palpated. And starting soft, going more firmly, he wasn't really complaining of any severe pain. It was a little tender, but it seemed to be tender everywhere that I palpated. He denied any pain with a Valsalva maneuver. He denied any pain with breathing. Rib palpation was normal, so truly it was an unusual scenario. In terms of that musculoskeletal evaluation, he did have a positive piano key sign on his left AC joint. He did have a positive AC joint compression test. Negative anterior, posterior, and lateral rib compression tests. So taking a look at those ribs, because he was complaining of that left-sided pain. Negative clavicle fracture assessments, percussion, direct palpation. There was no obvious deformity. There were no bruising signs, symptoms, nothing of that nature. The musculoskeletal evaluation of the shoulder was limited somewhat by the pain that he was having, supposedly from the anterior dislocation. So as I palpated around the AC joint, around the front of the shoulder, he was having some pain and tenderness. At this point, the parents are in the locker room with me. There's a family friend who had some sort of medical background from some point in his life, so he had a lot to offer in terms of a diagnosis and a differential. But for me, my differential now just exploded. And the differential has grown in size. So now I'm including possible spleen laceration, possible rib fracture or dislocation, possible intercostal contusion or strain, possible AC joint separation, definitive left shoulder anterior dislocation, and also likely concussion. As Larry has stated before, hollow organs have that greater ability to sustain trauma and stretch and absorb those forces. When we're talking about something like the dense, spongy, highly vascular spleen, much more susceptible to that high trauma injury. So the immediate treatment for him at this point, as I'm looking at him, the diaphoresis is continuing. He does look pale. It seemed to me like there was an altered level of awareness. He was conscious, alert, and oriented, but it seemed like he was a little out of it, which again, this is a student athlete that I'm not familiar with, so I don't know if this is normal for him. How does he typically behave as I turn to the father to ask how is he behaving, he's consulting with his medical friend in the corner, so not overly interested in what I had to offer. So what I decided to do is to sling and swath this patient because of the shoulder dislocation, because of that suspected AC joint separation now. Provided some ice, and I suggested emergency transport. The parent said to me, well, we're at this ice hockey rink where we play, and it is approximately 3 minutes from the level 1 trauma center right down the street. So can I just take him now? And I said, I'll be honest with you, given the signs and symptoms, this is borderline shock presentation. You need to go to the emergency room as soon as possible. And I think even how close you are, emergency ambulance would be appropriate. And the father insisted that he bring him. So because he was not deteriorating rapidly, I said, it's your call in working with high school athletes and their parents. Basically what they say goes. So they chose to bring him, the father chose to bring him in their personal vehicle to the emergency room, which was, again, just a couple minutes down the road. So what I actually ended up doing was giving him written directions of what to say when they went into the emergency room. Because if you're in my ambulance, then you're taken right in. You walk into the emergency room. If you just tell them, oh, my son went into the wards, he has some shoulder pain, they're going to sit him down and wait for an orthopedic consult for your shoulder. I said, I need you to give them these written directions of exactly what we're seeing here, because I think there's a possibility there could be something further going on. The official diagnosis, this was not my own student athlete, so I followed up with the athletic director from this visiting school, just out of my own professional curiosity and to see what happened. The official diagnosis was a grade 4 spleen laceration, 2 fractured ribs, 10 and 11 on the left side, left anterior shoulder dislocation, left acromioclavicular joint separation, and the grade was unconfirmed from the athletic director, and a mild concussion. So if you thought Andrew Luck was having a bad day, at least he was making $250,000 that day. This poor kid looked like he got into a bad car accident. The treatment was pain management and emergency CT scan. So in the slide here, which you'll have emailed to you, I did put some information, some studies on there. It is a new management trend for the spleen injuries to be non-operative. So even though this was a grade 4 spleen laceration, there was no physical treatment to the spleen. The student athlete remained in the hospital for, I believe, 4 to 5 days for medical observation and rest, and was released. Pediatric blunt spleen trauma does have a high mortality rate, or it has in the past, but CT scans in conjunction with measuring physiologic response, so basically watching how the patient is responding to the injury and to healing, has actually resulted in a high salvage rate for the spleen, and not having to actually remove it in that case of the girl who had her spleen removed with a pancreas. Again, medical observation, rest, some rehabilitative therapy for the shoulder injuries, and the patient was released, and he will be returning to ice hockey this season. I don't believe he played a spring sport, so I believe he took off the rest of the academic year, and will be returning to this season. So the uniqueness of this particular case study is that signs and symptoms of internal injuries can often present in this confluence of conflicting yet similar patterns. Musculoskeletal injuries of the left shoulder, mild traumatic brain injuries, occurring in concert with a splenic injury can present evaluative challenges to the certified athletic trainer and first responder. You have those physical, emotional, mental deficits that we see with concussions, feeling in a fog, poor concentration, fatigue, headaches, nausea, irritability, anxiety, moodiness. These things can coalesce with symptoms that are coming from internal injury, that altered level of awareness, the nausea, the vomiting. Simultaneously, we have a left AC joint injury, a left anterior shoulder dislocation, which are all causing increased pain for this student athlete. And at the same time, we're trying to utilize our best practice and evidence from potential referred pain pattern of Cursi. How do we discern between Cursi and pain secondary to AC joint or dislocation injuries? I don't really have a great answer for you on that. Truly what it comes down to is using your best judgment as a clinician and taking in the entire picture. What was the mechanism of injury? How is the patient presenting? How are the symptoms evolving over time? Some of the conclusions from this case study, from this particular scenario, athletic participation carries inherent risk always, regardless of the sport, regardless of the gender, regardless of certain circumstances. There are inherent risks to participants, and there are also inherent challenges to the clinician. And so as a practicing clinician who's out there dealing with these student athletes, whether they are college age, high school age, adults, regardless, you're going to face these challenges where you may not be able to discern one from the other, and nothing ever presents textbook. Clinicians must fully evaluate patients with mechanisms of injury, suggestive of internal injury, while obviously applying judicial consideration to any constellation of signs and symptoms. So again, looking at that mechanism of injury, looking at the different signs and symptoms, and as that doctor said about Drew Bledsoe, really thinking outside of the box. Finally, clinicians must recognize the need for emergency medical treatment in any instance of suspected internal injury in spite of conflicting signs and symptoms. So a younger clinician, somebody who is less experienced perhaps, out in the field with this particular scenario where you have that left shoulder dislocation, you have left AC joint, look at that mechanism of injury and say they don't need emergency medical treatment, you can take your time, watch the rest of the game, go get that checked out at the end, we'll put you in the sled, let me give you some ice. You can have these conflicting signs and symptoms, but really you need to look at that entire picture and use that as part of your decision making when it comes to your clinical judgment. Right now, I have my questions slide up. Does anyone have any questions?
So, just for sake of my conflicts with material, what if this had happened 3 minutes left in the game?
This was at the start of the second period.
So if it had happened, because it wasn't your athlete, so the
Right.
follow-up would have been difficult there. You would have just
Right.
long swab. Good luck, God bless.
Second, I mean, in this particular instance, walked, if he was presenting this way,
Yeah.
yeah, I mean, it delayed onset of signs and symptoms. So
Right.
we're lucky that we had that time to evaluate.
Yeah.
But certainly, as Larry said, it could take days, could take hours. Probably with a slow swab, put the ice on, send them with the parent. And I always use the red flag disclaimer after every injury to say, if anything changes, if anything seems concerning, altered level of consciousness is my go-to. As they walk out the door, they'll certainly seek immediate medical treatment.
Right. Because with a grade 4, he was probably bleeding pretty profusely.
Yeah, and that's what, they believe was secondary to the rib fractures. So they had the 2 rib fractures. So they think the ribs may have lacerated that, made it worse than having been constantly fractured. But yeah, the follow-up is critical, and it's tough, especially when it's not your own student athlete for that follow-up, so you kind of limit it that way.
Yeah.
Yes.
Okay, here's a addition to your case study. So, given everything you just said, now you're on the ice, they did not get up off the ice, this happened right. And add 2 head lacerations to that. With me and 2 EMTs and an orthopedic surgeon on the ice, EMTs arrived, and now there's a new trend and new regulation within my area of Central Mass that you do not spine guard anybody. So you have to get them up.
That's the whole, they just do a sleep inspection.
Yeah, you wanna touch on that?
Well,
So
so,
Ted, so technical.
and this, what was the mechanism of injury?
And actually, he went into the boards, hockey player went into the boards, sideways, shearing force, came down on his back, whiplash to the back of the head. From the replay that we got to see after the effect, I think the helmet came up and hit the ice directly, and then the helmet sliced the top of his head, like right on the top of his scalp, and then rolled over to the side and seized so badly grand mal that his legs were coming up like almost 12 inches off the ground. Now we arrived, we were in different rinks, we were covering 10 minutes at a time, of course. So when we arrived, he was post-ictal and Sarah straight out there. So at that point, we're dealing more with bleeding, bleeding shock, he's bleeding
Sure,
right now.
sure.
So we get the head injury under control.
Sure.
EMTs come in and really get him up on the ice. So then it turns into a cranial nerve, how much we do.
Right.
Absolutely, and full movement, hands, feet, ready to play. Like, let me up off the ice, I'm ready to play now.
Yeah.
But we didn't see the seizure until the instant replay that we got to watch afterwards. But we had 3 people run 2 blinks to warn us that this kid was shaking and bleeding on the ice. So we knew that there was a seizure just from, reporting and from his state, being post-ictal.
So, that's a.
So
pretty
priority,
wild-
yeah, it was intense. It was talked to, the whole rink went into this post-traumatic stress syndrome after that. The kids were crying
I
and,
believe-
it's
yeah,
like they didn't want to play, like it was just an absolute nightmare. But adding to what you're saying as far as priority goes, I mean, I have EMT experience, so, I had no problem taking on the situation, but, that part was the only part that was really the questionable, was the move.
Right.
Once we control the breathing, he's got no tenderness on his spine, he's
Right.
post-ictal.
Right.
How much real awareness do you have? So what are
So-
your telltale, like, okay, it's safe for liability right now to
Right.
let this kid off the
Right.
ice?
I mean, I don't know that there really is a telltale sign that we're 100% clear on this. Again, I think it comes down to your evidence, your best practice, and your clinical decision making. So for me to go out there and see that, I see the patient, he's moving on the ice, he's not completely still. As I approach him, I can hear him, the coach got out there before I was even able to get there, because his teammates brought him as I shuffled. But totally conscious, alert, oriented, there was no observable seizure-like activity. Initially going right back and palpating, no C-spine tenderness or pain, complaining primarily of that shoulder pain. So I made the decision to say, okay, do you feel comfortable enough to roll over and sit up? In terms of EMS, I'm definitely familiar with this trend from football and from other sports. As always, the communication's key, and sometimes it's tough if you're working with one of these big tournament style, many rinks, many teams, you may not know who's responding. I know for us in our town, we have a third-party ambulance company, so I take it upon myself to reach out to them and say, can you bring in a few of your regulars and discuss our EAP, can we discuss how we're going to handle these things? And then certainly in the event of injury, if EMS arrives, we maintain control. And we say, this is what we're going to do. I've had some bad experiences with EMTs, not knocking that profession or those individuals. It's just sometimes that power struggle occurs, and really, in the moment, I don't know that there's a way to prevent it as much as there is just proactively reaching out and having that discussion, and being aware of those updates, because that is an update. If there's no midline pain, they will not spine board, even if there's some other mechanism to suggest or indicate spine boarding, they may not, which seems crazy to me.
So I guess my case in this, being more specific, is did you get them off the ice? How would you get them off the ice? I mean, I
How would you
just
get them
looked
off
at the
the
kid and
ice?
said, you got any abs? He's like, I got 8 of them, and it was like,
Yeah.
okay, want to get up and let's
Yeah.
look at it. And he went right back to the bench, like he was
Right.
going, well, no, let's go to the stretcher.
Right.
Which was all the way, from here to there
Sure.
to get them off, but the EMTs would not come on the ice.
Oh, they wouldn't even come on the ice. Oh, okay, I thought they came out and then said, we're
No,
not
they
gonna
came
come.
to where the door,
Ah.
the exit door was at the edge of the oval.
That is
We don't
really-
sign anymore, you gotta get them off the ice. I'm like, okay.
Yeah, that's a little odd.
All
And
right.
it's number 3 of evaluation.
So I guess one of those baby Bjorn things of getting them.
Well, you can was gone to get the gurney.
No, the girl was there.
Oh no, I'm thinking like, say you did suspect a C-spine and they still wouldn't come on the ice. You could have
No,
gotten the
I
gurney
had,
and
I had a Buddha too, I had a Buddha. The girl was blind with her eyes open, no feeling in her arms and legs, was not feeling her arms and legs, was not moving. I could control the head, and the state trooper was like, we gotta get a spine board, and I'm like, yeah, no kidding, I'm not moving this kid until, you know, heat exhausted. And they came over and they went, okay, I'm ready to take over. I was like, you're gonna take over? What are you gonna do? And he just went, he's like, well, we have to set him up, we don't spine board anybody. This is a Devon's. And so I went, you want a spine board? You don't want to spine board this person. She's got no feeling from the waist up and she's blind with her eyes open. And I went like this, your liability, with the doctor standing there with two of them, and they went, and they pushed her up, flank up. And she came back 2 hours later with a diagnosis of a concussion and, I'm fine, I was like, oh, no.
There's that breakdown of communication, because what you're seeing, what you're evaluating is not getting relayed to the ED or to wherever they're going. So then they come in and there's a girl sitting there happy as a clam saying, I just have a headache. What you didn't know was the, post-ictal, seizure-like activity, whatever else went on. And that's scary. And that's where some of my negative interactions have come from, as I'm trying to give a history to the responding EMTs, and they don't want to hear that.
Or we're talking teams of doctors, as I was saying, they come sometimes, depending on how you call on the field, like if you call and say, we've got no feeling, we've got this, you'll get a doctor on the ambulance that comes out with you. And they're like, yeah, ready, we can fix anything, that's what the guy said, we can fix anything once we're in the hospital. And that's what I want to say, okay.
Great, so sit up and skate off with a broken hand.
Your liability.
Yeah, that's a scary situation. And I guess communication is really the key there. You can't control other people, and really it's transfer of care. So if they arrive and they refuse to do something, then now the liability is on them.
Yeah, I did tell the state trooper, I said, can you make sure that this moment with this
Yeah,
person,
take a mental snapshot.
said this,
Right.
and I'm out.
Right.
I'm transferring care over to
And
this.
I hate to say that, I mean, as in the helping profession, I hate to say, I'm just gonna dump it off, but truly, you can only do so much, we can only do so much. So at that point, legally speaking, transfer of care, they're assuming care of that patient and they choose to sit her up, potentially to her detriment. You're documented as dissenting, but.
It's just a scary trend, I just wanted to bring it up to your
It is.
case study, because.
Oh, absolutely.
it's not a trend, it's a change in that protocol.
Right,
Yeah.
no, that's.
Yeah.
So you're gonna keep seeing it.
There's no spine board in New Hampshire, but they will put the collar on and then they just use a scoop stretcher, but they won't put them on an actual spine board.
Were there any other questions or?
Let's bring Larry back up, see if anybody has any questions for, I actually have a question that I'm not sure which of you would be better to answer, but I do have a question myself.
Okay.
What's the determination for surgical versus conservative treatment of organ injuries?
I can take that one. So for the most part, they're going to try. The question was, what's the surgical or conservative treatment? What makes that decision? Majority of the time, they will try for the conservative treatment, medications, things that will maybe stop the bleeding for the liver. They may inject a catheter and some substance to seal some of the blood vessels to try to stop some minor bleeding. If after a couple days or a day, if they can't get the bleeding to stop with medications and conservative treatment, then you'll likely see them get to surgery. And then that will depend. Will they remove it? Will they take out 75% of something? Will they try to repair the injured tissue?
We can extend an injury.
Would they need replacement of this blood loss or fluid loss, IV?
That's definitely possible as well, depending on how much blood they may have lost into their abdominal cavity.
So in terms of replacing blood volume for any blood lost.
I would agree. That's definitely a possibility.
Yes.
Yeah, with the parents, were they reluctant to see that there could have been an internal injury at that point, or what was your feeling?
So in regards to any reluctance from case study patient's parents in seeing the injury. I wouldn't say they weren't reluctant to see that there was injury. I think there are certain stereotypes, there are certain parents or certain individuals who are more focused on the game, the outcome of the game, when can my child go back to the game, what is the quick extent of this injury, what is your x-ray vision telling you right now, so we can divine when this player can go back. My son has a D1 scholarship waiting for him in 4 years. So I can't tell you all of this. I can give you guidance based upon my background. And again, not to bring this back up, but there was this other individual in the room, and again, when it's just you and you're in the locker room and I'm focused on this patient and I'm trying to communicate with the parent, and you have this third party who was, you know, I don't know, a firefighter dispatcher 30 years ago, who is saying, this is my guidance and this is what you should do. Close family friend, they're listening to him in the corner. You can only stress it so much, which is why I think my discussion of emergency transport kind of was ignored largely. So they weren't reluctant to see the injury, they just were not focused on what I had to say necessarily.
Did the school from the patient, did they have an AT on staff?
I believe I could not find, so I wasn't familiar with the school, I wasn't familiar with whether they had an athletic trainer on staff or not. Typically, when it comes to these, any injury really, if I don't know the AT, I'll go online and do as much research as I can to find them, to locate them, and email or call or whatever. I couldn't find any information for one on staff, so I emailed the athletic director just to provide a brief background of what I did, what I saw, what the parents said, what happened, and then just to follow up with me if he could. I never heard back, so I proactively reached out to follow up. Again, out of professional curiosity, and that's where we learned all of this information when we got hit by a dump truck on ice.
It is absolutely essential to your little red flag to the parents, like, if this happens, boom, 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 seek immediate help. Because I also had a lacerated spleen, hockey injury, butt into the stick, check into the boards. Checked in between periods, and he was as white as a ghost and sweating profusely. It wasn't even a question to me. The rink was right behind the fire department. I called them, and the EMTs got there, and the parents said, no, we don't need that. And then the EMTs went, okay, it's your son.
Sure.
And I mean, I said to him, you really need to. And it was the dad who was that dad. But the mom was like, what do you think we should do? And I'm like, you should be at the hospital right now. This shouldn't even be a conversation we're happening. So she pulled him by and the dad, by the ear. They got him, and he was in surgery two hours later. So it was that bad that it required surgery. But you have to say that. Like, okay, well, if this and this happens, if the symptoms degrade this much, you need to get there. Because a lot of times they're in that fog, that parent game fog, where they're not seeing the whole picture. They're seeing the D1, or they're seeing, well, there's a scout here tonight. They're not seeing the other stuff, even though it's their child. I mean, obviously they want what's best for their child, but they have the fog.
Absolutely. And if I could even add to that, the tricky part, as we are all aware, is now this is also visiting school. So naturally, any advice that I have, any guidance, any insight that I have into a particular injury is obviously, because of my innate desire to throw the game in favor of my team. There's no professional ethics involved whatsoever. So I always give the disclaimer. I always say, listen, I can't be 100% right, but I feel strongly about this. This is what I'm seeing. These are what the signs and symptoms are telling me. And at this point, you may not need emergency. If it changes, if anything changes, you got to listen to your body and make that decision. And don't ever hesitate or wait. I think that got through to the father. I was very lucky for him to be receptive to me giving him written instructions to give to the ED when I got there, just so that they had something in mind, even if there was no internal trauma whatsoever, just to kind of expedite things. They would just sit bleeding out in the waiting room. So that is another another factor to this profession and to these types of instances is, you know, especially in a world where not every school has an athletic trainer, you know, you're covering, maybe the athletic trainer has to go somewhere else, now you're covering both teams, and dealing with your own parents can be challenging and frustrating and difficult enough, and dealing with these parents in the fog of who are you to talk to my child, who are you to talk to me, it's difficult to navigate that. But I just fall back on, you know, I went to school for this, you can listen to what I'm saying or you can't, but this is what I'm telling you. And we hope for the best outcome. Thankfully, in this scenario, the patient had the best outcome possible. But yeah.
Okay, I think we're getting close to wrapping up. For those of you on the webinar, don't forget that you can ask questions by typing in the little questions box. We'll get those answered. Also, please remember to download the handouts right now because we'll be closing this in